Well, good afternoon, everyone. This is Radcliffe Cardiology. I'm Mirvat Alasnag. I'm an interventional cardiologist based in Saudi Arabia. With me today is Professor Nick Curzen. He's a professor of interventional cardiology and the president of the British Cardiovascular Intervention Society. We'll be discussing the forecast trial today. Good afternoon, Professor Curzen.
Good afternoon.
So there was a predecessor to this study published by your group in 2016 that was more of a proof of concept. And in that study, you enrolled about 200 patients who underwent cardiac CT and FFRT, and a treatment strategy was determined based on the CT angio data alone. Now, the study demonstrated that the treatment strategy changed in 36% of the patients after obtaining the FFR data. So how did the design of the forecast trial actually differ from that initial trial?
Yeah, thanks. So the study that you're talking about was called FFRT Ripcord, and it was part of a series of investigations that were looking to validate the ability of FFRT to work and also alter management. And FFRT Ripcord was specifically designed to look at the difference in management that patients would undergo if they just had CTCA compared to if they had FFRT data with a CTCA. So it was mimicking an invasive study I'd done a few years earlier called Ripcord. And it was part of a validation series. And as you say, it showed that just over a third of cases, the management changed by consensus based on having FFRT data compared to just the CT angiogram data alone. Forecast was a completely different investigation. What it was looking to do primarily was to see whether by having FFRT as an upfront strategy, there would be cost savings in the way that NICE's assessment of FFRT a couple of years before had indicated there would be based on observational data. Now, I was dubious about whether that would be true, and I wanted to conduct a randomized trial specifically and assuming that FFRT does work, which I think is now being well established, specifically looking to see whether using FFRT as a strategy in the NHS system would indeed save as much money as the NICE technology appraisal had suggested based on the observational data.
Right, and before we just get into the results, the CT arm, a stenosis of 40%, prompted an FFR. So how did the investigators arrive at that cutoff?
Yeah, it's a fantastic question. Conventionally, I think a cutoff of 30% has been used a lot more, particularly for the other studies I've done invasively. I've done a series of studies looking at the use of an invasive FFR to assess the difference between just doing an angiogram. And I had used a 30% cutoff in those. The 40% cutoff came from really pragmatic considerations in forecast. Obviously, we knew that every time an FFRT assessment was done, that would cost another just over £500. And so we didn't want to commit this arm to as many FFRTs as we'd have to do if we lowered the threshold to 30%. We knew from studies like FFRT Ripcord that it's only a very small number of cases where there is a lesion of less than 40% that turn out to have an ischemic lesion on FFRT. So we basically took a very pragmatic approach and said we don't want to miss very many ischemic lesions that don't look severe on angiography, but we also don't want to send lots and lots of people to FFRT who are going to have a negative result.
So were there any variabilities that you noticed in those who underwent stress echo or cardiac MR or SPECT in the other arm?
No, not really. We haven't done a full sub-analysis of that, but there's no evidence that the non-invasive stress tests lead to a different outcome or a different comparative outcome. But we're doing a series of sub-analyses at the moment. I doubt they will reveal any difference based on the crude data that we've seen so far, though.
And while we're on the topic of subgroups, so those with significant atherosclerotic cardiovascular disease risk factors, such as diabetes, for example, were only about 12 to 13% of those enrolled in the forecast. Likewise, those with prior MI were excluded. So there's only a very small percentage of those that were evaluated. Do you believe the overall population studied in forecast was in fact low risk, and it may not be used for higher risk populations, interpretable for high risk populations?
Well, from the point of view of the risk profile, this is absolutely typical of the kind of patients who present with possible angina that needs a frontline test to help determine whether it is due to coronary disease. So this would be absolutely typical of the rapid access chest pain clinic type population we see in the UK, who are patients referred mainly from their primary care doctor to say, we're worried this is angina, can you find out for us? It's also very typical of other studies of this type. So, for example, Platform, which was the observational study upon which NICE made a lot of their modelling from, was an observational study looking at global patients with new onset chest pain undergoing assessment, and their rate of diabetes was 14%, for example. So I think this is actually fairly typical. By definition, when you're screening patients who may or may not have angina or stable coronary syndromes, they tend to be a lower risk population than other groups when you already know that they definitely have coronary disease.
So, FFRCT is not widely available across centers and across the globe. How many of your patients were, the FFR was difficult to actually obtain? And so how applicable is this technology to different centers that may not have the experience that yours does?
Yes, that's another very, very important question for this technology. In forecasts, just over 8% of the scans that were sent with the intention of getting an FFRCT result couldn't be analysed, so we weren't able to get an FFRCT result. And that's from the whole group all around the 11 centres in the UK. Again, this is about typical of the results that we've seen previously. In Platform, it was about 13% that couldn't be analysed, and it's been a lower percentage in other data, for example, from the advanced registry, it was lower than that. So 8% is about average. I wouldn't say that's a particularly startling outcome, because the quality of CT angiography obviously varies enormously depending on lots of factors, including the centre, the specific people doing the test, but also the patients, what their heart rate is, how successful they were at getting the heart rate down. But behind your question, there's a very important point, which is when a centre starts sending CT angiographic data to HeartFlow for FFRCT analysis, they do request that they go through a quality control process that's managed by HeartFlow to try and ensure that the methodology they use to acquire their CT data, it fits with the output that HeartFlow need. I think there's always going to be a failure rate for any test, and I guess the failure rate we're seeing here would probably be about typical. And we're going to have to accept that if we're going to use FFRCT in the front line.
So if we move on to the results themselves, the primary endpoint demonstrated no significant difference in resources, utilizations, and cost at 9 months. There wasn't a significant reduction in invasive angiography in CT FFR group, unlike your earlier trial. And there wasn't a significant difference in quality of life, angina, and major adverse cardiac events. So overall, where do you think CT FFR fits into the scheme of evaluating patients with chronic coronary syndromes now?
So again, that's really the critical question here. What we found was that there was the FFRCT strategy was not cost dominant. And I think that, to me, wasn't a huge surprise, because the modelling that we've seen previously showed, from observational studies, showed that FFRCT was cost dominant in patients who would have otherwise had an invasive angiogram, but it wasn't cost dominant in the patients who would have had a non-invasive stress test first. And of course, in real life, in a randomized trial, we have both of those cohorts in the study. So for me, it wasn't a huge surprise. And this is one of the reasons I did the study, because I was dubious about whether it would be very cost dominant. we saw that 22% fewer patients in the FFRCT arm in forecast needed an invasive coronary angiogram, which of course, if you're one of those patients, is very attractive because no one wants to have an angiogram unless they want one. So that was a positive outcome. But there was no difference in clinical endpoints, as you said. And I think that's to be expected because if we look at the other observational studies that have been done before, what we see is that FFRCT has consistently reduced the number of invasive angiograms that need to be done, and it's consistently reduced the number of angiograms that show unobstructed coronaries, but it hasn't, in the end, reduced event rates because it's just picking people who don't need angiography. So the answer to your question is, my personal interpretation of forecasts is that we can probably be smarter at using FFRCT, which is undoubtedly a very useful clinical tool, but we can probably be smarter about deciding who needs the test and when. So my interpretation of this is now that if you take into account the powerful results of ischemia and courage before it, the best strategy for these patients would be to do a CT coronary angiogram up front and find out whether they have atheroma. If they have atheroma, we know that they would benefit prognostically from getting optimal medical therapy. And if they've got angina and atheroma, we know that they would benefit from optimal medical therapy and anti-anginal therapy. I would then put them on those medications and follow them up in a few weeks' time. If they're still getting angina, I think it's likely they would then benefit from revascularization according to ischemia. And I would probably then send their CT data, which of course would be in hand, for FFRCT analysis. And I would use that FFRCT analysis to then discuss with them the best step forward, whether it be PCI type revascularization or possibly bypass type revasc. And I would then take patients to the cath lab, having made a pretty decent plan. Obviously, the FFRCT PCI planning tool may well turn out to be a useful addition to planning the process with the patient. And then I'd take them to the cath lab, and if the results turn out to be consistent, I would then go ahead with either the PCI or refer them for bypass surgery. By doing that, we would not over-revascularize patients, which is what ischemia has probably told us we've done before. And it would also reduce the number of cases that actually need FFRCT in this context. And that may well alter the balance to make this cost dominant.
So you're an interventional cardiologist, and do you see as the role of FFRCT picking up in this subset of patients, chronic coronary syndromes, do you see the role of invasive FFR or physiologic assessment, FFR or IFR, start to kind of dwindle down in this new scheme that you're recommending?
I think probably when we look to the future, we can expect the role of invasive pressure assessment to go down for two reasons. One is that FFRCT will supply us with an upfront assessment of ischemia, and it is lesion specific and pretty well validated. So if you've done FFRCT, you probably don't need to do an intracoronary pressure wire. Furthermore, there is some very exciting work going on to suggest that if you have FFRCT that is high quality, you may in the future be able to refer patients who you don't want to intervene on yourself for bypass surgery without them ever having an invasive angiogram. Third, I think the software that is looking at angiogram-derived FFR, in other words, FFR or IFR derived from invasive angiography, those models are now getting to the stage where they look as though they'll be ready for frontline clinical practice in the next few years. So that will further reduce the need of the intracoronary pressure wire. My only caveat is that currently we're seeing quite appropriately a very large momentum building in the field of angina without epicardial coronary disease. And at the moment, as far as I'm aware, apart from some types of MRI, we don't have a good alternative tool for making a very specific diagnosis of microvascular angina without putting a wire down the coronary. So that may preserve some intracoronary work that we currently aren't doing. So there's a sort of balance to be had, I think.
Yeah, that's an interesting point you bring about that. So given that you're addressing resource utilizations and costs, and given that the NHS invested a lot in FFRCT already up until this point, what do you think the implications of forecast for that policy is going to be down the line?
Well, I think we have to assume that as forecast was specifically designed to look at relative cost dominance of FFRCT as a frontline strategy in a randomized setting in the NHS system, I think we have to assume that this strategy where FFRCT was paid for on the basis of modelling from observational data needs to be reviewed, because the expectancy from the National Institute of Health and Clinical Excellence that an FFRCT upfront strategy would save a lot of money is probably now called into question by forecast. That does not mean that I don't think we should be using FFRCT, but I suspect that we probably need to refine the way we're using it rather than just making it available effectively for free in the expectation it will save the NHS money. So it probably will need a bit of thought about exactly where this sits in frontline clinical practice now.
And do you think down the line there's a chance that the cost is actually going to come down, and that may in the future change the implications of forecast?
I mean, I would have thought as it becomes a more and more popular test, it's likely the cost will go down, because that's what happens in nearly all business models. We're doing sensitivity analyses on forecasts which aren't ready yet to model whether there would be a threshold level of pound sterling that FFRCT could be costed at that would make this a cost dominant strategy. The early indications are that would be very, very difficult. It would have to be extremely cheap. But I don't think that matters. I would emphasize that the test, to be clinically important, doesn't need to be cost saving. The reason this result is interesting is because the estimates in the NHS that it would save so much money are probably flawed based on this. But a test doesn't need to save money. Remember, in our randomized trial, which is the only randomized trial available, it was cost neutral. So it's not that it's costing the NHS money, it's just that it's not saving it nearly as much as it was anticipated. So I suspect that FFRCT has an important role in these patients and possibly in other patients, including acute coronary syndromes, based on the preliminary data. But for me, this highlights the importance of having randomized trial data as well as observational prior to making strategy plans, because I suspect that the strategy that we've been pursuing may have some flaws in it based on this.
Well, thank you very much for your time. And I think this was a very elaborate discussion of the forecast trial. And,
well, thank you for your time as well. That's very kind of you.
All right, we'll see you in another episode of Radcliffe Cardiology.